Welcome to PGOG, postgraduate class in obstetrics and gynecology for postgraduates, undergraduates, as well as consultants. Today's topic is hypertension in pregnancy management for case-based learning. Now we call preeclampsia as a syndrome, and the reason why it is called as syndrome is it is a pregnancy-specific disorder which can affect almost every organ system in the body. And it is the most dangerous type of hypertensive disorders in pregnancy. We can divide preeclampsia into four types as per the time of onset, such as early onset is gestational age when it is less than 34 weeks and preeclampsia uh, starts. This is also a feature of severe type of hypertensive disease in pregnancy whenever the hypertension is detected for the first time before 34 weeks. Late onset is whenever it starts at greater than or equal to 34 weeks of pregnancy, which is comparatively a less severe form as compared to the early onset. Then we can also call it as preterm preeclampsia whenever it is present before 37 weeks, as the management changes, especially the decisions about the termination of pregnancy, depend on the gestational age, and that is why this is another way. Preterm preeclampsia is when it occurs less than 37 weeks, and term when it is present at greater than or equal to 37 weeks. Now, can this disease be prevented? Can we prevent it? So only drug which is available is low dose aspirin, though there are many studies which were conducted previously on the use of high dose calcium, on the use of other micronutrients or dietary supplementations or salt restriction or about the folic acid supplementation, but none of these have been proved. Only drug which shows a promise as far as prevention of preeclampsia goes is low dose aspirin with a dose of 75 to 150 milligram per day, to be started from 12 weeks of pregnancy and to be continued till delivery, and it should be started in high risk group with any one of the risk factors is on this side, left side, and any two of the risk factors is on this right side. So any one of the risk factors, in that there are total 5. Previous history of hypertensive disorders in pregnancy. In the previous pregnancy, if there is a history, patient has got autoimmune disease such as SLE or APLA. She is a case of chronic hypertension, chronic kidney disease, or diabetes, which can be either type 1 or type 2. Any one of these is an indication to start low dose aspirin. So in OPD, whenever you are sitting in OPD and you see the patient at 12 weeks, it is important to see whether there is any indication to initiate low dose aspirin therapy. Now, if there are two factors, then also we should be starting it, and that is why this list is also equally important. Nulliparity with an age greater than 40 years, or family history of hypertensive disorders in pregnancy, presence of obesity, multiple pregnancy, or interval between the two pregnancies greater than 10 years. Now, of any of these, there are total 6 factors, and any of these 2 factors will be an indication. Again, suppose a patient comes to us and she has multiple pregnancy and she is nulliparous. That means it is a clear-cut indication to start low dose aspirin. There is no role of salt restriction in prevention of hypertensive disorders in pregnancy. Now, this we will learn about the management of this hypertensive disorders in pregnancy as a case-based form, or on the basis of a case scenario, because that is easier to understand. What I thought, that rather than theoretically going through the management options and various reasons for the change in the management, it is better to take it as a case scenario. And in obstetrics, as you all know, the patient's condition is very dynamic. It changes from day to day, and an obstetrician needs to adapt to the changing clinical condition of the patient and change the management almost on day-to-day basis, or sometimes from hour-to-hour basis also, and that is the reason what I thought that this case-based scenario learning will make it more practical, more useful, and interesting for all of us. So case is she is a primary gravida with gestational age of 35 weeks. Though she is coming regularly for the antenatal checkup, for the first time now when she has come for a routine antenatal checkup, her blood pressure is 150 by 100 mmHg. Before that, her blood pressure recordings were normal. That is less than 140 by 90. So the first time the blood pressure shows a rise of 150 by 100 millimeters of mercury for the first time in pregnancy. So how should we proceed? The first step will be hospitalization. We need to hospitalize her. Now, when should we hospitalize a patient? Whenever there is a rise in blood pressure for the first time in pregnancy, then we should admit, and that rise is if systolic is greater than or equal to 140 millimeters of mercury, or diastolic blood pressure greater than or equal to 90 millimeters of mercury, or both, then we should hospitalize. Now, what is the aim of hospitalization? Why we are hospitalizing the patient? If you are asked, why do you want to hospitalize? Now, this is a very common case you get in examination. That in the long case, you get a patient who is a diagnosed case of any one of the types of hypertensive disorders in pregnancy, and your viva will go in the similar lines. If you say I will hospitalize her, then you will be asked what is the reason, why do you want to hospitalize? So it is first thing is to confirm the diagnosis, then to determine what is the type of hypertensive disorder in pregnancy in the present case, and to again to diagnose related to the severity of the disease. So these are the three main reasons: confirmation of diagnosis, determination of the type, and to diagnose the severity. Diagnosis of hypertension: whenever systolic blood pressure is greater than or equal to 140 millimeters of mercury, and or diastolic blood pressure greater than or equal to 90 mmHg. What is not used anywhere anymore, which was previously used and which you will find in the older editions of the textbooks also, that the definition previously included rise in systolic of greater than 30 and diastolic greater than 15 was also over the baseline was also included, but it is no more being used. Now, some guidelines or some textbooks still do mention this 4 to 6 hours apart. If you repeat the blood pressure, and if it shows a persistence of the raised blood pressure, then only to call it as hypertension, but it is not used in many of the guidelines. Even a single rise in the systolic or the diastolic above this 140 or 90 mmHg respectively is sufficient to diagnose it as a case of hypertension. What are the types of hypertensive disorders in pregnancy, and what is the how the severity increases? That this we have already seen in the terminologies and diagnosis of the hypertensive disorders in pregnancy, which is available in the previous video, and students are requested to go through that video first so that you will understand better. But in short, we have four types. First is gestational hypertension, then is a chronic hypertension, which is comparatively more severe, then is preeclampsia, which is more severe than these two, and the maximum severity has preeclampsia superimposed on chronic hypertension. So these are the four types, and this is how the severity keeps on increasing. How we diagnose preeclampsia is whenever there is a hypertension with proteinuria. That we all know, hypertension with proteinuria. But now the latest recommendation is we should, even if there is absence of proteinuria, then also we should be diagnosing a case of preeclampsia dependent on these 5 features as thrombocytopenia, renal insufficiency, liver involvement, cerebral symptoms, and pulmonary edema. This has to be at the tip of the tongue for all the consultants and students, because whenever we get a case of hypertensive disorders in pregnancy, we need to focus on these 5 parameters which help us to diagnose preeclampsia even in absence of proteinuria. Now the question is, how do we diagnose proteinuria? Previously it was said given that if you collect the urine for 24 hours, and send it for the assessment, and if that shows a presence of proteinuria of greater than or equal to 300 milligram, it was said to be a diagnostic test for presence of proteinuria. It is no more being recommended, and it is quite cumbersome, and we have a better test available now by which you can do the urine protein creatinine ratio. There is no need to keep on collecting the urine for 24 hours, and it is reliable test. So most reliable, most commonly used test to diagnose proteinuria, most reliable as well as most commonly used is urine protein creatinine ratio, and if that ratio is greater than or equal to 0.3, then it is diagnostic of presence of proteinuria, significant to diagnose it as a case of preeclampsia whenever it is present along with hypertension. Now, if these two tests are not available, then only one should be diagnosing proteinuria by using a dipstick, and if it shows a presence of greater than or equal to persistence of 1 plus urine albumin, then also you can consider it as presence of proteinuria to diagnose it as preeclampsia. But the better is, even if it is positive, we should then say confirm it by doing urine protein creatinine ratio, that because sometimes with contamination or UTI, it can be false positive 1 plus or greater than 1 plus presence of proteinuria by dipstick method, and that is why if it shows that, then we should confirm it by doing urine protein creatinine ratio, and it helps us to even quantify how much is the proteinuria when we do urine protein creatinine ratio. For this, we have to do platelet count, and it is less than 1 lakh per microliter is diagnostic of thrombocytopenia. Renal insufficiency, creatinine greater than 1.1 milligram per dl or double of the normal if previously done, and it shows a rise of twice of the normal, then also it is renal insufficiency to label it as a case of preeclampsia. Serum transaminases are also double of the normal, and then that shows liver involvement indicating preeclampsia. Cerebral symptoms such as headache, visual disturbances or convulsions, and pulmonary edema. So if you focus on these, proteinuria indicates that the disease is affecting the mainly there is a affection disease affecting the kidneys. But all the end organs, if these are getting affected, and then mainly the preeclampsia is almost affecting all the organ systems in the body, and these five reflect indirectly this end organ involvement with the vasculopathy which is present with preeclampsia, and that is why these are also sufficient. Any one of these is sufficient to diagnose it as a case of preeclampsia. This is most important slide, and by this time, I hope that it is at the tip of the tongue for of all the postgraduates. Other types of hypertensive disorders in pregnancy, how we diagnose is gestational hypertension is when there is a rise in blood pressure after 20 weeks with no features of preeclampsia. Chronic hypertension is rise in BP before pregnancy or before 20 weeks of before, that is pre-pregnancy, or before 20 weeks of pregnancy, or both. How we diagnose superimposed preeclampsia or in a case of chronic hypertension is there is sudden rise in new onset rise in blood pressure. Though patient is on antihypertensive, suddenly she is showing a rise of blood pressure in spite of taking regularly the antihypertensive medications. New onset proteinuria, any of the features of preeclampsia, whatever we have seen till now, as thrombocytopenia, liver or renal insufficiency, liver derangement, or cerebral symptoms or pulmonary edema. 20 to 50% of chronic hypertensive patients have superimposed preeclampsia, and that is why every chronic hypertension we need to carefully monitor the patient, as it can progress into superimposed preeclampsia, which is the most dangerous type of the hypertensive disorder in pregnancy. Even gestational hypertension, 50% go for preeclampsia. So that is how all these, though initially we diagnose a case in any of these categories, it has a potential to move to a more serious disease, which is preeclampsia. Early on, and this whenever there is a superimposed preeclampsia in chronic hypertension, it is early onset, more severe with increased risk of IUGR as compared to the pure cases, that is where there is a preeclampsia without preceding chronic hypertension. Now, how to diagnose severe, non-severe? This is also we have seen in last class, but I am repeating it once again because it is the most important concept which decides in the management. It is as per ACOG 2020 recommendations. On this side are already whatever we diagnose preeclampsia, again those features are again repeated with a division of this cerebral into separately three: headache, visual disturbances, convulsions, thrombocytopenia, renal insufficiency, liver involvement, pulmonary edema. So it is easier to remember that these are the features which help us to diagnose preeclampsia in absence of proteinuria, as well as these features are suggestive of a severe disease. But apart from this left-sided list is important, that sometimes these might not be there, but still disease might be in a severe category, such as patient has got gestational hypertension. She is a case of gestational hypertension, but suddenly now she is showing a systolic blood pressure greater than or equal to 160 mmHg. That hypertensive disorder in pregnancy case is now labeled as a gestational hypertension with severe variety. Severe gestational hypertension, so that the management will change completely if there is any of these severe features. Diastolic greater than or equal to 110. Early onset hypertensive disease in pregnancy less than 34 weeks. IUGR, presence of IUGR is indirectly telling us that with the end organ involvement of other organs, there is also involvement of placental circulation, chronic placental insufficiency. So that is also suggestive of a presence of a severe degree of the disease. Oliguria, that is significant, and upper abdominal pain, which might be because of the involvement of the hepatic subcapsular hemorrhages, or sometimes there are also gastric hemorrhages with eminent eclampsia, and that is why it is also suggestive of a epigastric pain or right-sided pain in the upper abdomen. That is also suggestive of a severe degree of the disease. Now, most important sentence is non-severe can rapidly progress to severe. Now we come back to the present case. We have been given a case that patient is 35 weeks and she has come to us with the first time rising blood pressure to the OPD. And what we are doing in the present case is we are doing the investigations: CBC, platelet count, KFT, LFT, ultrasonography for the fetal size and amniotic fluid volume, and test for fetal well-being depending on availability. Either non-stress test or biophysical profile can be done. Now, I have given this in yellow as a question mark: uric acid, LDH, and coagulation profile. This as baseline, there is a question mark about the utility of this test. If there is a change in the severity, then we can proceed with these investigations, and that is why I have given it a question mark, that it is not mandatory as per the textbooks to do it as a primary investigation in a case of hypertensive disorder in pregnancy. So all these investigations we are doing, mainly we want to know whether it is a case of gestational hypertension or it is a case of preeclampsia in the present given case. Now these investigations should be repeated as per the disease severity. How much is the rise in blood pressure? What are the baseline investigation reports? Accordingly, we have to keep on repeating them. These sometimes even alternate day, twice a week, or in a very severe case, we might have to do it on a daily basis. So in our case, all investigations are normal. Patient is now kept in the hospital with the monitoring of blood pressure every 4 hourly and investigations to be done every alternate day. Blood pressure is in the range of 140 by 90 to 150 by 100 mmHg. She is showing a persistent rise in blood pressure. Fetal monitoring is continued with a biweekly biophysical profile and NST test. That is the plan of treatment as per ACOG 2020. In non-severe hypertensive disease in pregnancy, we need to do the fetal monitoring, and biweekly monitoring is sufficient. At present, what we diagnose it as a case, she is a case of gestational hypertension, which is of non-severe category. So non-severe disease is there, and she has gestational hypertension because she has no proteinuria. She has no other 5 features suggestive of any one of the 5 features suggesting preeclampsia, and that is why, and blood pressure is showing a rise after 20 weeks for the first time. So diagnosis is gestational hypertension. Plan of management with the present status is to keep her in the hospital and continue the conservative management in 38 weeks if the situation remains same. So that is as per the ACOG guideline 2020. In a gestational hypertension, we terminate pregnancy at 38 weeks provided everything else is normal. Now, role of anti-hypertensive treatment in hypertensive disorders in pregnancy. Labetalol is the first drug of choice, but some studies show that if we give labetalol for a long duration, it can lead to the increase in the rate of IUGR, especially if it is given in non-severe disease. And it is mainly the reason which has been given is whenever we do the control of blood pressure, and if there is a drastic reduction in blood pressure, that hampers the placental perfusion. Already there is chronic placental insufficiency usually whenever there is a hypertension in pregnancy. With that, if there is a sudden fall in blood pressure after taking antihypertensive medication, it further hampers the placental perfusion leading to IUGR. So too tight a control is not recommended whenever we give antihypertensives in hypertension in pregnancy. Nifedipine is the second drug of choice. Goal of this antihypertensive treatment is most important. It is to maintain blood pressure around 135/85 is the latest recommendation which has been given. So this is very important given by NICE guideline 2023 that the blood pressure to be maintained. NICE guideline 2023 as latest as possible says that whenever we give antihypertensives, we should not be aiming for the blood pressure to fall below 120/80. That will invariably lead to further reduction in the placental perfusion. So it has to be around 135/85. So we need to titrate the dosage of the drugs to maintain these around this. So another most important concept is antihypertensive treatment. With antihypertensive treatment, there is no improvement in maternal and perinatal outcome. Multiple studies have been done with the randomized control trials also, where one group was given antihypertensives, other was not given in a non-severe disease. And that what it ultimately the conclusion is there is no improvement in maternal and perinatal outcome with the antihypertensive treatment, and there is no prevention of eclampsia. Now, whenever what happens is we admit the patient and we start antihypertensive and the blood pressure falls, and we have a false sense of security that as if we have cured the disease. But we have to remember that disease process continues, and mainly the disease process here is vasculopathy, which is hampering the blood perfusion to all the end organs, and that process continues. And that is why we should not have a false sense of we should not relax. Though the blood pressure is coming to around this range, 135/85, we need to monitor the patient carefully. Main advantage of this antihypertensive treatment is it reduces the episodes of sudden and severe rise in BP. Because whenever there is a sudden and severe rise in blood pressure, what we are worried about is the hypertension leading to pulmonary edema, leading to intracranial hemorrhage, leading to cardiac failure. All these are prevented when we give. That is one advantage. But otherwise, the disease process continues, and all the complications which are arising because of the disease itself, such as eclampsia, abruption, pulmonary edema, HELP syndrome, all these occur irrespective of whether patient is on antihypertensives or not. Now it is day 4 for our patient, and she is on tablet labetalol, which has been started with the initial dose of 100 milligram twice a day, with a plan to increase it by another 100 milligram every third day, depending on the blood pressure control. Our goal of blood pressure control of 130/85 mmHg was achieved with a dose of labetalol 200 milligram twice a day in our patient. All investigations were which we are going repeating every alternate day. They are showing they were within normal limits, except dipstick method for proteinuria showed +1 result. As it came +1, which was initially negative, urine protein creatinine ratio was done, and which also came as greater than 0.3, confirming the presence of proteinuria along with the raised blood pressure in our patient, but no other features of severe disease. All severe disease features, they were not present. With that, now the diagnosis changed. From initially it was gestational hypertension of non-severe category. Now the diagnosis is preeclampsia, which is of non-severe category. Plan of treatment remains same for both, whether it is non-severe gestational hypertension or preeclampsia. Expected management till 38 weeks and termination of pregnancy at 38 weeks with careful monitoring provided the situation remains same. This is again the repetition, diagnosis of proteinuria, dipstick method greater than or equal to +1, which is a less reliable method. 24-hour urine protein measurement is usually not recommended now. Urine protein creatinine ratio is done to quantify proteinuria if dipstick is greater than or equal to +1. Now, first morning sample is not taken in pregnancy, as results of the first morning sample are less reliable to diagnose proteinuria. Now it is day 6 of our patient's hospitalization. All the investigations are within normal limit except blood pressure rise is there, which is now in spite of giving labetalol 200 milligram twice a day. She's showing a rise of 170 by 100 mmHg. That means systolic has crossed the this figure of 160. Anytime the systolic blood pressure greater than or equal to 160 mmHg, it becomes a severe disease. So she is showing a rise now, and platelet count is now 90,000 per microliter, which was previously normal. So she is showing thrombocytopenia, as well as she is now showing a rise in systolic blood pressure greater than 160 mmHg. Baby is fine with the NST biophysical profile within normal limit. There are no other features of preeclampsia, such as no cerebral features. We need to ask the patient in such a situation whether she is having headache. New onset headache, not responding to analgesic, is a feature of imminent eclampsia. Visual disturbances. Imminent eclampsia is now next few hours she can have a convulsion, and that is why we need to assess the patient and examine the patient with these. And there are no features of pulmonary edema. So in this case, how we know the type is hypertension is for the first time in this patient at 35 weeks. So there is no question of having a chronic hypertension. She has either a gestational hypertension or preeclampsia. Now, because she has proteinuria, as well as there is a proteinuria, so she has preeclampsia. And as she has thrombocytopenia and systolic blood pressure greater than 160 mmHg or equal to 160 mmHg, it is now she has a severe preeclampsia. So that will be the diagnosis. So that is how what I said is obstetrics is dynamic, and the disease keeps on evolving, and the patient's condition also keeps on changing, and we need to be on our tip of toes mainly to diagnose and assess the patient on a almost hour to hour basis in such a scenario. So now she has severe. So now the case summary is her gestational age is 35 plus 6 weeks. She has severe preeclampsia. Non-stress was is in within normal limits. Now we are doing all these investigations, repeating KFT, LFT. We are doing lactate dehydrogenase to see whether there is hemolysis. Coagulation profile is also done. Peripheral smear is to be done to see whether there are features of hemolysis such as broken RBCs are there, and CBC to be done. All these investigations were within normal limits, and what with that we are ruling out the HELP syndrome, though she has thrombocytopenia, that is hemolysis, elevated liver enzymes, and low platelet is the HELP syndrome which has been ruled out. Her cervix is unfavorable as expected in a primary gravida at 35 plus 6 weeks. With this diagnosis of severe preeclampsia with a gestational age of 35 plus 6 weeks, decision for induction of labor was taken to terminate the pregnancy with induction of labor by giving by using misoprostol per vaginally 25 microgram every 6 hourly. Anti-hypertensives were continued, and these are continued, and prophylactic magnesium sulfate was started because she has now severe preeclampsia, and we have taken a decision to terminate the pregnancy. The same dose the dose we use in eclampsia, with the same dose magnesium sulfate therapy is started. Now, why termination of pregnancy in severe preeclampsia? You will be asked, why suddenly be a non-severe? You said we can continue till 38 weeks, but suddenly she is showing severe degree, and we are changing our decision for an immediate termination of pregnancy. Why? Reason is maternal risk of placental abruption, eclampsia, pulmonary edema, renal failure, intracranial hemorrhage, HELP syndrome. All these are very serious complications leading either to serious maternal morbidity, or even sometimes maternal mortality also can result if we fail to take action at this stage, fail to terminate the pregnancy. So continued expectant management has risk of all these possible complications. And that is the reason there is no place of expectant management after 34 weeks if the disease is severe. Because already the baby is has crossed 34 weeks, we expect that chances of perinatal survival are better after 34 weeks, and we do not want to take chance to subject the mother to all these potentially dangerous complications, and that is the reason termination of pregnancy is indicated in severe preeclampsia, especially when gestational age is beyond 34 weeks. What is the place of expectant management in severe preeclampsia? It is only there is a place whenever gestational age is less than 34 weeks, but beyond gestational age, where the possibility of survival is present in the given setup, such as if the severe preeclampsia is at a say 26 weeks, then from place to place the decision might change whether to give a expectant management for few weeks or whether to terminate the pregnancy as per the neonatal facilities or preterm baby facilities. But whenever it is less than 34 weeks, then only the possibility of expectant management arises, option arises. Otherwise, beyond greater than or equal to 34 weeks, there is no place for expectant management. Whenever we are thinking about expectant management, we have to ensure that patient doesn't have any other serious complications such as abruption, HELP syndrome, or eclampsia. She needs a careful daily monitoring. We can give expectant management for the completion of steroid therapy whenever the gestation age is less than 34 weeks. That can be another scenario where we are giving in spite of disease being severe. In every case, on an individual case basis, patient to patient, we have to weigh maternal risk against the neonatal risk to take a decision about the termination of pregnancy, because whenever we are giving expectant management for better neonatal outcome, we have to remember that we are subjecting mother for the life-threatening complications. Proper consent is to be taken by explaining the situation to the patient as well as to the relatives. Again, most important is controlled blood pressure does not prevent complications. What happens is whenever you admit a patient and start to give her antihypertensives and her blood pressure is under control, the relatives are under the impression as if her disease has been cured. So you need to explain to them also that blood pressure is under control, but still she can have any time a life-threatening complication, and we have to weigh that risk against the risk of prematurity related complications in the newborn baby. Now, why we give prophylactic magnesium sulfate, which is given in severe preeclampsia prophylactically. When do you give? Only when delivery is expected in next 24 hours. Otherwise, if you want to keep most important is, if you want to give expectant management even in spite of patient being severe preeclampsia with a gestational age, if it is less than 34 weeks, say patient has got 30 weeks pregnancy and severe preeclampsia, and you want to give her at least 8 to 10 days for the better neonatal outcome. In these cases, we won't give prophylactic magnesium sulfate. It is to be given whenever delivery is expected in next 24 hours, because we know that chances of eclampsia are greater in the intrapartum. and immediate postpartum period. That is why we are giving it whenever the delivery is expected in next 24 hours. And secondly, we do not want to keep on repeating magnesium sulfate. It is dangerous for the baby if it is given for a prolonged duration, leading to neonatal fractures also. That is why we do not want to give magnesium sulfate repeatedly. It is given for total duration of 24 hours whenever it is being given prophylactically. It is not given for prolonged duration. After 24 hours, we stop this magnesium sulfate therapy. And careful monitoring is required to prevent the toxicity as we do the monitoring in a case of eclampsia. Students are, again, I remind them that they have to go through the video on magnesium sulfate in pregnancy, which is already available on this PGOG YouTube channel. Now, corticosteroids to improve fetal lung maturity. Present case gestation age is 35 plus 6 weeks. She needs termination in view of severe preeclampsia. In such a case, single dose of corticosteroid is to be given. But what is important is not to wait for completion of steroid therapy for induction. This is most important. As gestational age is already greater than 34 weeks, one need not wait for completion of steroid therapy. The risk of complications is too high. Gestational age is already greater than 34 weeks. We give first dose, but we don't wait for the completion of the dose to start induction. That is most important take home message. Whenever gestational age is greater than 34 weeks, we initiate steroid therapy, but we do not wait for completion to initiate the induction. Simultaneously, we do induction of labor also, or we do termination of pregnancy simultaneously. Now, important is corticosteroid previously were tried as treatment for HELLP syndrome, but now it is proven by various studies that they have no role as in the treatment of HELLP syndrome. So they are not given in any case of hypertensive disorder in pregnancy as a treatment of HELLP syndrome. Corticosteroids are only given if for the improvement in fetal lung maturity. And again, for details, students can go through the video corticosteroids in pregnancy, which is also available at PGOG. Now our case continues. Patient goes in labor 12 hours after induction of labor with tablet with misoprostol given vaginally, 25 micrograms, 6 hourly. Now she is in latent phase of labor with cervical dilatation of 2 centimeters. Magnesium sulfate infusion is stopped after completion of 24 hours of administration. But now her blood pressure is showing 180 by 120 mmHg in spite of being given the labetalol as it was given before induction. So during labor, there is a episode of, this is called as episode of severe rise in blood pressure or hypertensive crisis. So in treatment of hypertensive crisis is mainly to not only to prevent intracranial hemorrhage, but also we want to prevent occurrence of pulmonary edema, occurrence of cardiac failure because of this sudden rise in blood pressure. First drug of choice is IV labetalol. First, it is given initially as 10 milligram bolus. Wait for 10 minutes. Still, blood pressure is in the severe category, greater than 160 systolic or 110 diastolic. Then repeat dose 20 milligram. Wait for 10 minutes. Again, take blood pressure. Persistent rise, then 40 milligram. Repeat again another 40 milligram. Still no response, you can give a 80 milligram as high as this much. So this is the how the gradually you increase the dose of IV labetalol. Each time you give, you have to first take the BP, see that it is still not, it has not reduced to systolic less than 160, diastolic less than 110 mmHg. Then only you repeat the dose as per the requirement in a given patient. Or one can give a constant infusion of labetalol with 1 to 2 milligram per minute. If you have an infusion pump, you can use this also. Total maximum dose on a given day should not exceed 220 milligram. Now this labetalol, we have to remember, it should not be given in asthmatics. So in asthmatics, this is contraindicated as it can precipitate asthma. It has less side effects as compared to hydralazine or nifedipine. That is the advantage of labetalol, and that is why it has emerged as the first line drug for hypertensive crisis in the intravenous drug administration form. Second is hydralazine. It is given 5 milligram either intravenously or intramuscularly as the first initial bolus dose, and then 10 milligram every 20 minutes. It is to be given same way. Take the blood pressure and then only decide about the next dose administration, and total maximum 3 doses can be given like that every 20 minutes. It has got more side effects such as tachycardia, fall in blood pressure, sudden hypotension are more with hydralazine as compared to labetalol, and it is at some places it is not available. Now, if you are at a place where intravenous route is not established and you want a immediate effect with a sudden rise in blood pressure, we can go for tablet nifedipine. Tablet nifedipine is associated with greater episodes of sudden hypotension, and that is the reason labetalol is preferred over nifedipine. 10 milligram tablet to be given. After 20 minutes, you again repeat blood pressure. If required, you give 20 milligram. Still raised blood pressure, you can repeat 20 milligram one more time. So this is how the nifedipine can be given for hypertensive crisis. Whether we should use diuretics in non-pregnant patients, the combination of antihypertensives and diuretics are commonly used to control the blood pressure. But in pregnancy, it is given only to treat pulmonary edema. It is not used to control hypertension in pregnancy. Reason is placental circulation is already compromised in hypertensive disorders in pregnancy, and diuretics will further reduce the placental blood flow and adversely affect the baby, leading to many a times even intrauterine growth restriction or sometimes intrauterine death also, and that is why it is contraindicated. Only indication is pulmonary edema. Now our case continues. She is in early labor with cervical dilatation 3 centimeters. Continuous CTG monitoring is done in this case, as these are the patients who are likely to have already they might be having the placental insufficiency. So CTG in this patient shows now absent variability with baseline bradycardia, which is, and on per vaginal examination there is no cord presentation, back of membranes is intact. So if absent variability is there, bit to bit variability is absent, and baseline bradycardia is also there, where the fetal heart rate is less than 120 per minute, then in that case it is diagnosed as a case of category 3 by National Institute of Child Health and Human Development, NICHD, Fetal Heart Rate Classification System 2008. So this CTG is category 3. That means it is an indication for immediate termination of pregnancy. So decision to proceed with emergency LSCS was taken in our patient. Till the time patient is being shifted and in a cesarean section baby is delivered out, intrauterine resuscitation is started with lateral position, maternal position, and to start IV fluid crystalloids. But in this case, we cannot give 1000 ml bolus IV as indicated for other non-hypertensive patients for as a intrauterine resuscitative measure. Here we can give 80 ml per hour, not more than greater than that. Now, I want postgraduate students to be very clear about the categories, NICHD categories of this CTG, as well as about intrauterine resuscitation, because it can be life-saving for the baby. Now, what is the recommendation about fluid therapy in severe preeclampsia? Oral liquids are to be given as far as possible if patient is in labor. Avoid giving IV fluids whenever she is in for vaginal delivery. IV fluids are to be restricted, that is the norm, because pulmonary edema occurs if there is a hyperperfusion of crystalloids. So many times we have seen that we have managed a patient beautifully and she has delivered, and on day 2 or day 3 suddenly what we find is she has pulmonary edema, and it is usually iatrogenic in origin, that we have given too many IV fluids to her, and with hyperperfusion These are the patients who are more prone to develop pulmonary edema. So how much IV fluids to be given? A dictum is to give 80 ml per hour crystalloids and not greater than that. And plasma volume expanders are not given usually in these women unless for some reason you are giving diuretic, then only you can give. Otherwise, plasma volume expanders are contraindicated for the same reason that this can also lead to pulmonary edema. Now, in our patient, latest repeat investigations are within normal limit except platelet count 1 lakh per microliter. Spinal anesthesia can be given whenever platelet count is greater than 70,000 per microliter. That is why it is important to have a latest report of the platelet count whenever we take a decision for emergency cesarean section. So, in our patient, emergency cesarean section was done under spinal anesthesia. Baby is well. Prophylactic oxytocin was given as 10 units intravenously after the delivery of the baby. In spite of that patient now has atonic postpartum hemorrhage with approximate blood loss of 1 liter. And now her blood pressure is 120 by 80 mmHg. You are operating on her and you are closing the uterus, and what you find is suddenly there is a gush of blood, uterus is flabby, and blood loss is around 1 liter apart from our usual blood loss of the cesarean section, additional blood loss of 1 liter. Now, PPH prevention and management in hypertensive disorders. Methyl ergometrin is contraindicated prophylactically because of the risk of sudden rise in blood pressure. Prophylactically, it is contraindicated. What is important to remember as a clinician is it can be given therapeutically with a dose of 0.4 milligram intravenously. That sometimes patient is suddenly going in hemorrhagic shock. It is better to give methyl ergometrin, manage her PPH, and then if she shows a rise in blood pressure, we can take care of that by giving intravenous, even labetalol also if it is a persistent rise. So comparatively, this hemorrhagic shock is difficult to manage in these women rather than sudden hypertension. So it can be given therapeutically. That you remember. Aggressive management of postpartum hemorrhage is a must whenever a patient is a case of hypertensive disorder in pregnancy. High concentration oxytocin drip to be given, carboprost 250 microgram to be given intramuscularly, and misoprostol 800 microgram to be given per rectally. So with that, in our patient, bleeding was controlled. With that, 2 units of PRC is also given as her blood pressure suddenly showing 120 by 80, which was persistently raised, is indicator that there is a fall in blood pressure because of this blood loss. 1 liter blood loss also too much to tolerate for a case of severe preeclampsia, and you need to take a earlier decision to give the pack red cell transfusions in these women. So this is a very favorite question of examiners. Why hypertensive disorders in pregnancy and combination of PPH is a dangerous combination, and sometimes why we lose the patient. Why it can even lead to maternal mortality also is, in these cases, hemodilution of pregnancy is absent. That is the first thing we need to understand, that hemodilution protects a woman whenever there is a blood loss during pregnancy, delivery or cesarean section, because what she is losing is mostly the plasma when there is a hemodilution. Plasma she is losing and less of RBCs. But there is a hemo concentration on the other hand in these women. So plasma is less comparatively. Whatever is blood is running in the blood vessels, it has more of RBCs. That is how the proportion of the plasma and RBCs changes. There is a hemo concentration, more of RBCs, less of plasma. So whenever there is a blood loss, she is losing more RBCs as compared to a non-hypertensive woman. Visually also you can see the same blood loss in a normal pregnancy and in hypertensive disorders in pregnancy. Here RBC loss is less. This hypervolemia is protecting the mother. But because there is hemo concentration, hypervolemia is not there. On the other hand, there is a hemodilution is not there. On the other hand, there is hemo concentration. Whatever she is losing is mostly RBCs. So patient develops early features of hemorrhagic shock if we don't aggressively treat her PPH and we don't provide her with the necessary blood component therapy. She might not tolerate even normal blood loss, severe preeclampsia or eclampsia. That is most important. Sometimes we say that blood loss is normal and we tend to forget that even that much of the blood loss she might not tolerate. She might show features of sudden drop in blood pressure and hemorrhagic shock if we do not take care of her condition with aggressive management. Now, postpartum care, blood pressure monitoring was done in our patient, which showed a persistent rise of blood pressure, and so tablet labetalol 200 milligram was continued, and then patient was discharged. Thank you so much. These are the references, mainly Williams Obstetrics 2019, and NICE guideline has given quite clearly 2023 latest guideline is there, and students also can go through it to understand the management in a case of hypertensive disorder in pregnancy. Thank you once again.